This is Jeremy with Clarity, and in this video we're going to be going over the bony anatomy of the upper extremity. Now, to begin, we're going to be talking about the clavicle. And the clavicle is the correct anatomical name for what most people know as their collarbone. It's S-shaped and the superior surface is smooth, the inferior surface is rough, the medial end is round, and the lateral end is flat. The medial half of the clavicle bows out anteriorly, while the lateral half bows out posteriorly. This is important to note, but also easy to remember because you can feel it or palpate it on yourself. The rounded medial end of the clavicle is known as the sternal end. That's because it articulates with the manubrium of the sternum. That articulation is known as the sternoclavicular joint, which is a saddle-type synovial diarthrodial joint. What's unique about that is it's the only bony articulation that the upper extremity has with the axial skeleton. On the other end of the clavicle, we have the acromial end. This is known as the acromial end because it articulates with the acromion process of the scapula. This is the acromion process of the scapula, and this is the acromial end of the clavicle. It's broader and flatter than that narrower and rounder sternal end, and it makes sense if we add the last bony component of the shoulder complex. Looking at this, we can see how the acromion process of the scapula, and therefore the acromial end of the clavicle, both lie superior to the glenohumeral articulation. The glenohumeral articulation is a ball and socket type synovial diarthrodial joint made between the glenoid cavity of the scapula and the humeral head. This articulation is important in helping us make sense as to why that lateral aspect of the clavicle is broader and flatter. That's because ball and socket type synovial joints are the most mobile synovial joints and therefore the most mobile joints, period. They allow for movements such as circumduction to occur, which is that movement in which you can move your arm in a smooth circular pattern. Noting that, it makes sense as to why this lateral or acromial end of the clavicle is broader and flatter, to allow more room for that humeral head to move around. Now, the sternal end and the acromial ends of the clavicle are not the only bony features. If we look at the inferior surface, we see this big bony prominence. This is known as the conoid tubercle of the clavicle. Projecting laterally from it, we have what's known as the trapezoid line. And both of these bony landmarks are important because they serve as important attachment sites for the coracoclavicular ligaments. That is, the ligaments between the coracoid process of the scapula and the clavicle. These ligaments specifically attach on the conoid tubercle of the clavicle and the trapezoid line of the clavicle. Hence, why those are two important attachment sites for the coracoclavicular ligaments. Finally, right around the middle third of the inferior surface of the clavicle, we have what's known as the subclavian groove. This is important because it serves as an attachment site for the subclavius muscle, that is, the muscle beneath the clavicle. So, to give a quick recap, the clavicle has four surfaces: smooth superior, rough inferior, round medial, and flat lateral. The inferior surface has three bony landmarks: the conoid tubercle and the trapezoid line, which both serve as important attachment sites for the coracoclavicular ligament complex. And the third landmark is the subclavian groove. Now, to orient the clavicle and determine whether it's right or left, there's a few things to consider. First, that rounded sternal end must be medial. Not only that, but we have to make sure the conoid tubercle is inferior and posterior. Another way to help you remember that is that the medial half of the clavicle bows anterior. This is probably one of the easiest to remember simply because you can palpate it on yourself. If you ever get confused, just reach up and try to palpate your own clavicle, as that medial half will be easier to feel because the medial end first bows out anteriorly. And the reason this is so important is because if we only note that the sternal end is medial, we may confuse ourselves and think that this is the correct orientation for the clavicle. But this is not, as the medial end, in this sense, bows out posteriorly, and the lateral bows out anteriorly. Again, this is wrong because if we just palpate our own clavicles, we know that that medial end is easier to feel, telling us this is a left clavicle. To move on, we have the scapula. Most people refer to this bone as their shoulder blade, and together, your shoulder blade and your collarbone, or your scapula and your clavicle, help create the bony anatomy of your shoulder or pectoral girdle. The correct anatomical name for your shoulder blade is the scapula. And the scapula is relatively triangular in nature. Therefore, it's going to have three sides, or three borders: the superior border, the medial border, and the lateral border. And that's because we reference the scapula in this position: superior border, lateral border, and your medial border. Now, this medial border is also referred to as your spinal or vertebral border, and that's because this is the border that faces your spine and therefore your vertebra, while your lateral border is also known as your axillary border, and that's because this border faces your axilla or your armpit region. And we also know that this is the lateral border of the scapula simply because here is our glenoid cavity. And as we said earlier, that humerus articulates with the glenoid cavity, specifically the humeral head, to form that ball and socket type synovial diarthrodial joint. Now, it only makes sense that the humeral head articulates with the glenoid cavity on the lateral aspect of the scapula because we all know that our arms are lateral or to the sides of our body. Otherwise, where would our torso be? Continuing on, other than the three borders, we have three angles. We have the superior angle of the scapula, the inferior angle of the scapula, and although we don't have a true third or lateral angle of the scapula, we have the glenoid cavity, which kind of acts in place as to where that would be. Continuing on with the rule of threes in this sense and this triangular analogy, other than the three borders and three angles, we have three fossa. But before we get into what the fossa are, we have to point out that this is the scapular spine. And the most lateral extension of this scapular spine is referred to as our acromion process. And we've been talking about this as whenever we talked about the clavicle, specifically because that articulates with the clavicle, specifically the acromial end or that lateral end of the clavicle. So the lateral end of the clavicle articulates with the acromion process, which exists on the lateral aspect of the scapula. These are all lateral structures. Now, anterior or in front of this acromion process, we have what's known as the coracoid process. And to get back to those fossa, because this is our scapular spine, we first needed to name it, as we have two fossa that are named in relation to it. We have our supraspinous fossa, which exists in this area. Supra implies above, spinous refers to the scapular spine, and fossa tells you that it's a depressed landmark. Similar to our supraspinous fossa, we have an infraspinous fossa. Infra tells you below, spinous again refers to that scapular spine, and fossa, once again, tells you it's a depressed landmark. Now, the third fossa is the one and only fossa that exists on the anterior surface of the scapula. And this is referred to as our subscapular fossa. Sub implies underneath, and the best way to make sense of this is if we had a posterior view of the scapula. And in this sense, the patient would be prone and we're looking at their left scapula. And the fossa that we just named, or the fossa on the anterior aspect of the scapula, is now on the fossa beneath or under the scapula. Therefore, this is the subscapular fossa. The other way you can differentiate this is because these two pair together. And the reason they pair together is because they are both named in relation to the scapular spine. Therefore, if you don't see the scapular spine, on the side of the scapula you're looking at by process of elimination, this is the subscapular fossa. Now, other than the three angles, the three borders, and the three fossa, and the two processes, we have the glenoid cavity. Now, logically speaking, we only have two scapular angles, but again, for the purpose of that triangular analogy, the glenoid cavity acts in place as the third. And the glenoid cavity has two tubercular extensions, one above and one below. Therefore, we have a supraglenoid tubercle and an infraglenoid tubercle, both of which act as attachment sites for the long head of the biceps brachii muscle and the long head of the triceps brachii muscle, respectively. Lastly, we have two notches. First, we have this suprascapular notch, supra implying above, scapula referring to what it is above because it's above the scapula, and notch telling you what type of landmark it is. Now, if you were to identify this bony landmark, you would need to say it's the suprascapular notch of the scapula. And although that sounds a little redundant, if we break down the actual terminology, it'll make more sense. Suprascapular just tells you it's above the scapula, and notch again just tells you what kind of bony landmark it is. So if we only say suprascapular notch, then we just know it's a notch above the scapula, but we don't know it's on the actual scapula itself. Therefore, you must say the suprascapular notch of the scapula. Now, the other notch is the spinal glenoid notch. And if we're, again, to break down that terminology, spinal refers to the scapular spine, and glenoid refers to the glenoid cavity. Therefore, the notch between the scapular spine and the glenoid cavity is that spinal glenoid notch. So to give a quick recap, the scapula has three borders: the superior, the medial, and the lateral. If we look at it on the posterior aspect, the superior, the lateral, and the medial. And this medial is also referred to as the spinal or vertebral border, while this lateral is also referred to as the axillary border. We have two true angles, the superior angle of the scapula and the inferior angle of the scapula. And we have the glenoid cavity that kind of acts in place as where the third angle would be. We have three fossa, two of which are named in relation to the scapular spine, the supraspinous fossa and the infraspinous fossa. The last being the subscapular fossa, which is the only one on the anterior aspect of the scapula. We have two processes, the acromion process, which just acts as the lateral extension of the scapular spine, and the coracoid process. We have two tubercles, the supraglenoid tubercle and the infraglenoid tubercle. And then we have two notches, the suprascapular notch and the spinal glenoid notch. Now, to give a quick tip over how you can best orient the scapula, the first one is going to be to know that the subscapular fossa is on the anterior aspect of the scapula. That is going to be one of the biggest tips, because if you see the subscapular fossa, that means you're looking at the front or anterior aspect of the scapula. Whereas if you see the scapular spine, you're looking at the posterior aspect. The next biggest hint is going to be the glenoid cavity. The glenoid cavity must be lateral. Again, that's because it helps form that ball and socket type synovial diarthrodial joint with the humeral head, and because the humeral head is of the humerus and the humerus is our arm bone and our arms are on the sides or lateral to our body, it only makes sense that the bony landmark it articulates with, aka the glenoid cavity, must face laterally as well. So if we look at the scapula like this, we see the subscapular fossa is facing us. Therefore, we're looking at it anteriorly. And the lateral side is the side with the glenoid cavity. So this, if we orient it or visualize it in our minds, we'd have to flip it over to know that that glenoid cavity is lateral, that subscapular fossa is anterior, and that the scapular spine is posterior, telling us that this is a left scapula. Now that we've discussed the most proximal bony anatomy of the upper extremity, with that being the shoulder, aka pectoral girdle, and therefore consisting of the scapula, aka shoulder blade, and clavicle, aka collarbone, we can start talking about a more distal structure, with that being the arm bone, which is correctly termed the humerus. Now, to start with the humerus, we can go over what we've been naming, the humeral head. Now, as we've talked about, the humeral head forms, well, we've talked about it enough. See that without rewinding the video, if you can tell me what type of joint the humeral head forms with the glenoid cavity of the scapula. So what type of joint it forms, what that joint is classified as functionally, and what that joint is classified as structurally. And if you would like me to do a video on types of joints and their functional and structural classifications in the future, just let me know down below. Just as we have a humeral head, we have a humeral neck. But what's unique about the humerus is we have two necks, an anatomical neck of the humerus that separates the humeral head from the greater and lesser tubercles, and a surgical neck of the humerus that, although contrary to what most people believe, is not important for surgical procedures, but is a common fracture site of the humerus that requires surgical repair. The greater and lesser tubercles are two tubercles, and the only two tubercles on the humerus. And they serve as the attachment sites for our four rotator cuff muscles. So two tubercles serve as the attachment sites for our four rotator cuff muscles. One's termed the greater tubercle, and that's because 3 out of the 4 rotator cuff muscles attach here, whereas the lesser tubercle only has one rotator cuff muscle that attaches there. And that makes sense, as following Wolff's law, which says that bone adapts to the stresses placed upon it, it makes sense that the tubercle that has 3 muscles attaching to it is greater than the tubercle that only has 1. Now my question to you is, what is the log, or what is the law that is homogeneous to Wolff's law but for soft tissue? So just as Wolff's law says that bone adapts to the stresses placed upon it, what law says that but for soft tissues instead of osseous tissues? Now between these two tubercles, we have a groove or a sulcus. And groove and sulcus are sometimes used interchangeably, so make sure you know which one your professor is asking for. This is the intertubercular groove, with inter meaning between and tubercular referring to the two tubercles, as this is the groove between two tubercles. But it's also referred to as the bicipital groove, with bicipital implying biceps brachii muscle, as the tendon of the long head of the biceps brachii muscle runs through this intertubercular groove before it attaches to that supraglenoid tubercle of the scapula. That just makes sense. So this is our intertubercular, aka bicipital groove, or sulcus. Right around mid-shaft of the humerus, we have 2 bony landmarks. One on the more anterior lateral aspect, being the deltoid tuberosity, which serves as an attachment site for our deltoid muscles, and one on the posterior aspect of the humeral shaft, which is termed our radial or spiral groove. It's termed the radial groove because it corresponds to the path of the radial nerve, or the nerve that innervates most of the posterior muscles, aka extensor muscles of the upper extremity, lies. But it's also termed the spiral groove simply because it takes a spiral path. Looking at the distal end of the humerus, we see the one and only humeral condyle. But this one condyle has 2 components, a trochlea and a capitulum. Trochlea stands for spool-like structure, and capitulum stands for little head, both of which directly correspond to what these structures look like. Now, above each condylar component of this humerus, we have 2 bony prominences. We have a medial and a lateral epicondyle. Epi refers to above, and condyle refers to condyle. So the 2 bony prominences above the 2 condylar components are both the medial and lateral epicondyles, respectively. The medial epicondyle will always project further than the lateral, therefore the lateral will be less prominent, and that will help you with the bony orientation of the humerus. Now above each epicondyle, we have a ridge. Therefore, we have a medial and lateral supracondylar ridge, a ridge above the condyles. Supra implies above, condylar implies condyle, and ridge tells you what type of bony landmark that is. So we have one distal condyle with 2 condylar components, the trochlea and the capitulum. And we have 4 bony landmarks above those 2 condylar components. 2 of them are medial, 2 of them are lateral, 2 of them are epicondyles, and 2 of them are supracondylar ridges. To wrap things up, we have 3 fossa. We have the olecranon fossa of the humerus that corresponds with the olecranon process of the ulna, and this is the only fossa on the posterior aspect of the humerus. We have the coronoid fossa of the humerus that directly corresponds to the coronoid process of the ulna, and we have the radial fossa, which is a little difficult to see here, but you can still make it out. And this is the radial fossa of the humerus that directly corresponds to the radial head. Now, to give a quick recap, here's our humeral head. We have 1 humeral head. We have 2 humeral necks, an anatomical and a surgical. We have 2 tubercles, a greater and a lesser. We have 2 grooves, one being the intertubercular, aka bicipital groove or sulcus, and one being the radial, aka spiral groove. We have 1 tuberosity, with that being the deltoid tuberosity, and we have 1 condyle with 2 condylar components, 1 medial and 1 lateral, with those being the trochlea and the capitulum, and each one directly corresponds to an antebrachial or forearm bone, with the trochlea being associated with the ulna and the capitulum being associated with the radius. And above each condylar component, we have an epicondyle, a medial and a lateral respectively, meaning we have 2 epicondyles, and just as we have 2 epicondyles, we have 2 supracondylar ridges, a medial and a lateral. And we have 3 fossa, olecranon fossa, coronoid fossa, and radial fossa, respectively. Now, just as we finished going over the humerus or the arm bone, we can start talking about what's next in the upper extremity, that being the forearm or the antebrachium, and therefore the 2 bones that make it. Now, the first bone of the forearm that we're going to be talking about is the ulna. But before we get to that, I want to give some direct tips for helping orient the humerus. Whenever we talk about the humerus, and specifically the distal aspect, and more specifically the distal posterior aspect of the humerus, we find that olecranon fossa. So anytime you see this, you know you're on the posterior aspect of the humerus. Looking at the anterior aspect of the humerus, and specifically the anterior distal aspect of the humerus, we see the trochlea and the capitulum. The trochlea will always be medial, as it's associated with the ulna, which is the medial bone of the forearm. And that relationship will help you determine not just that the trochlea is medial, but that the ulna is the medial bone of the forearm as well. So it's bidirectional. To reinforce this, and probably an easier way to remember this, the medial epicondyle, or the bigger projecting condyle of the humerus, is medial. So this medial epicondyle will always project further than the lateral, and therefore will be more prominent. Looking at the proximal humerus, the humeral head will always face medially, and that's because it articulates with the glenoid cavity of the scapula, which is a laterally facing structure. The lesser tubercle sits more anteriorly, and the greater tubercle sits more laterally. So taking all of that into consideration and looking at this humerus, we see it's a left humerus. The humeral head faces medially, the lesser tubercle sits anteriorly while the greater sits laterally, and looking distally, we have that trochlea sitting medially, and we know that because it's reinforced by this bigger projecting medial epicondyle. Going to the ulna. Here we have the olecranon process, and that's the correct anatomical name for what most people point to whenever they reference their elbow. That olecranon process has a little brother. That little brother is the coronoid process of the ulna, and between these 2 processes, we have the trochlear notch of the ulna. Now, those 3 bony landmarks are relatively inseparable, and they're inseparable to the coronoid fossa of the humerus, the trochlea of the humerus, and the olecranon fossa of the humerus. Because together, these 6 bony landmarks help contribute the most to that flexion and extension that occurs at the elbow. So it's a unique relationship in that on the ulna, we have 2 convexities with 1 concavity, and on the humerus, we have 2 concavities with 1 convexity. Just as we have a trochlear notch on the ulna, we have a radial notch as well. The radial notch on the ulna is for the radial head, or the head of the radius. Therefore, we know it must be oriented laterally because the radius is the lateral bone of the forearm. Now, if we look distally, we have the ulnar head, and we have the styloid process of the ulna. The styloid process of the ulna is a distal medial structure. So when orienting the ulna, there's three main things to consider. The styloid process, which must not just be distal but medial, the radial notch, which must be proximal and lateral, and the trochlear notch must be anterior, or this U must be facing U to be anterior. That's how we know that this is a left ulna. But before we move on, now is an important time to talk about the differentiation between three of the most commonly mixed up bony landmarks of the upper extremity. Those being the coronoid process of the ulna, the coracoid process of the scapula, and the conoid tubercle of the clavicle. Now, a tip to help differentiate these. Whenever we say hooray, we throw our arms up in the air. Whenever we throw our arms up in the air, our humerus is being elevated, and with humeral elevation, our scapula moves. There's a scapulohumeral rhythm. So the scapula moves whenever our arm goes up, and our arm goes up whenever we say hooray. So whenever we say hooray, the coracoid process goes with it. So coracoid process, hooray. Coracoid has an R and an A, just like the word hooray does. So the bone that moves whenever our arms go up in the air is the bone that moves whenever we say hooray. So that's how you correlate the coracoid process of the scapula with hooray, and that's how you differentiate it from something like the coronoid process of the ulna. Coronoid process of the ulna, it has an R and an O. And if you just add a W, you have row, and most of the time whenever we do a rowing movement, our elbow is bent and is kind of retracting in that manner, or that's the action of rowing. And the coronoid process of the ulna is not the only coronoid process in the body. We also have a coronoid process of the mandible. And the muscle that attaches here is our temporalis muscle, and that muscle sits on top of our temporal bone. So with the fiber orientation demonstrated here by the probe, whenever that muscle contracts, it pulls backward. So it retracts whenever it contracts, or it simulates that rowing movement. So both coronoid processes are associated with some form of movement that simulates rowing. So you row with the coronoid, and you say hooray with the coracoid. This last one is the conoid tubercle. Conoid is the shortest word out of all three. It doesn't have a RA, it doesn't have a RO. So the shortest word, being conoid, goes with the shortest bone in this sense, the clavicle. So now that we've covered the ulna, and we've talked about one of the most confusing topics whenever we talk about bony landmarks of the upper extremity, we can start talking about the radius. The radius is the lateral bone of the forearm. It too, like the ulna, has a head, but the head of the radius is located proximally, whereas the head of the ulna is located distally. The head of the radius, just like we have a head, we have a neck. The neck of the radius is just inferior to it, and it's this part that I can wrap my finger around. And right inferior to the neck of the radius, which is inferior to the head of the radius, we have the radial tuberosity. And the radial tuberosity is an important attachment site for the conjoint tendon of the biceps brachii muscle, meaning both the short head of the biceps brachii muscle and the long head of the biceps brachii muscle share a common tendon that inserts or attaches to the radial tuberosity. So we have the radial head, the radial neck, and the radial tuberosity. We also have a styloid process of the radius. The styloid process of the radius is going to be a laterally oriented structure, just as the styloid process of the ulna was a medially oriented structure, because the radius is the lateral bone of the forearm. Last but not least, on the posterior distal aspect of the radius, we have what's known as the dorsal or Lister's tubercle. So, to help you orient the radius, to give a quick recap, we have one radial head, one radial neck, one radial tuberosity, one process, which is the styloid process, and one tubercle, which is that dorsal or Lister's tubercle. The radial head is proximal, and the anterior surface of the radius, specifically on the distal aspect or the distal end, is smooth, whereas the posterior is roughened and where that dorsal or Lister's tubercle is located. So if we put the radius and the ulna side by side, we can see how that radial head articulates with the radial notch of the ulna. Similarly, a bony landmark that I have yet to mention so far on the radius is the ulnar notch. So just as we had a radial notch of the ulna, we have a ulnar notch of the radius, and that articulates with the ulnar head. So the two heads of the two forearm bones articulate with respective notches on each forearm bone as well. The radial head articulates with the radial notch of the ulna, and the ulnar head articulates with the ulnar notch of the radius. Now, this is what they look like side by side. So on the ulna, we can see how that trochlear notch faces anteriorly and that radial notch faces laterally, while that radial head articulates with the radial notch of the ulna, and that radial tuberosity faces medially, while the styloid process of each bone faces in the respective orientation of which each sits in the forearm, meaning the styloid process of the ulna faces medially, while the styloid process of the radius is located more laterally. That's the orientation of the two forearm bones and the bony landmarks that consist of them. And to wrap things up, we have the hand. Not just the hand, but the wrist as well. Collectively, this consists of 8 carpal bones, or 8 bones of the wrist, as the Latin term for wrist is carpus, 5 metacarpals, and 14 phalanges. The best mnemonic to remember the carpal bones is straight line to pinky, here comes the thumb. That lists the 4 proximal carpal bones followed by the 4 distal carpal bones in a lateral to medial, medial to lateral pattern. Those being scaphoid, lunate, triquetrum, pisiform, hamate, capitate, trapezoid, trapezium. Scaphoid, lunate, triquetrum, pisiform, hamate, capitate, trapezoid, trapezium. Straight line to pinky, here comes the thumb. Meaning the 2 most lateral carpal bones are trapezium distally, scaphoid proximally, and the 2 most medial are the pisiform proximally and hamate distally. And just as the pisiform is a bony prominence projecting on the anterior or palmar aspect of the wrist, the hook of hamate is a bony landmark that does the same, but in the distal carpal row. So that's the mnemonic for the carpal bones. Next we have the metacarpals, and the first metacarpal is the one that's most lateral, or the first metacarpal, aka the smallest number, goes with the shortest digit, the thumb. Metacarpal 1, 2, 3, 4, and 5. Next we have the phalanges. The phalanges and the metacarpals share the same general anatomy, meaning each has a base shaft head. Base shaft head, base shaft head. Now the thumb only has a proximal and distal phalanx, while digits 2 through 5 have a proximal, intermediate, and distal. The joint between the distal and intermediate phalanges is the DIP, or distal interphalangeal joint, while the joint between the intermediate and proximal phalanges is the PIP, or proximal interphalangeal joint. The thumb, being that it only has a proximal and distal phalanx, has an IP joint, the just one interphalangeal joint. And all interphalangeal joints, be it the IP joint or any DIP or PIP joint, is a hinge type synovial diarthrodial joint. The joint between the proximal phalanx and the metacarpal is called the MCP, or metacarpal phalangeal joint, and all of those are condyloid or ellipsoid type synovial diarthrodial joints. The joints between the metacarpals and the carpals, or the carpo-metacarpal joints, well, digits 2 through 5 carpal metacarpal joints, CMC joints, are plane type or gliding type synovial diarthrodial joints, just like the intercarpal joints, the joints between the carpals. But that first carpal metacarpal joint, or that first CMC joint, which is of the thumb, is a saddle type synovial diarthrodial joint, similar to that SC or sternoclavicular joint that we talked about when mentioning the clavicle. So this is the hand and wrist in a nutshell. 8 carpal bones, 5 metacarpals, and 14 phalanges. That covers all of the bony anatomy of the upper extremity. If this video helped, leave a like, comment, subscribe, tell me your favorite part, and look forward to the future videos in which we'll be doing quiz style content with these same topics.